Well, good morning, everyone, and thank you so much for the opportunity to contribute to this great session where we're really reviewing some of the most challenging cases that we see in foregut surgery, and this really being no exception when you're faced with a patient who has, unfortunately, recurrent dysphagia after a previous myotomy for achalasia. I have no financial disclosures to report related to this presentation, but I would kind of like to establish a baseline that this is a very big topic and this could go way into the weeds in terms of assessment of subtle motility disorders. But in order to be more concise and give you guys some better take-home recommendations, I am really going to focus just on patients with true achalasia and those that have undergone a previous myotomy, either Heller or Pohm, and focus on that main complaint of dysphagia. The other baseline that I'd really like to establish is something that I tell all my patients, and that is that I really believe that achalasia is a chronic disease. And while our myotomies may relieve the obstruction at the GE junction and dramatically improve quality of life, there's a second component of the disease, which is that dysfunctional peristalsis, which our interventions don't really affect. So in some sense, what we're doing is a bit palliative. And in that case, some degree of persistent dysphagia is very common and perhaps even expected in the setting of a patient with achalasia. Now, that's not to say that myotomies don't work. We know that myotomies are extremely effective for the primary treatment of achalasia. In fact, surgical myotomy is associated with an 80 to 90% initial clinical response rate when it's applied to appropriately selected patients. Now, unfortunately, about 10 to 30% will develop recurrent symptoms that are bothersome enough to prompt their representation to our clinics. Now, only a minority of those, somewhere between 1 and 6%, are going to need any repeat interventions, but this is still a population that we need to be aware of and have treatment options for. Unfortunately, this can really happen anytime. While the mean time to recurrence of these symptoms is about 1.5 years, we've all seen patients with immediate recurrence of symptoms indicating a treatment failure, or there are plenty of reports of patients coming back 6, 10, even 15 years after a successful myotomy with recurrent problems. So why is it that these myotomies fail? Well, I like to think about myotomy failure into two big categories. One being, is this problem still with the valve? So is it perhaps too tight? Was there an incomplete myotomy, a problem with the fundoplication? Have they developed a mass? Has maybe actually that valve gotten too loose and they're suffering from GERD and inflammation in that region? Or is the problem more in the esophageal body? Are there progressive motility problems, tortuosity, sigmoidization, things like that, or even progression to end-stage disease? And the real problem is that it's almost impossible to know, based on symptoms alone, which of those issues you're dealing with, because every single one of them can present with dysphagia. Every single one of them can present with regurgitation, and they all mimic one another. So I really feel that if you're going to approach a patient with recurrent symptoms after a previous myotomy, it's vitally important to basically start back at ground zero. And that means doing a full and complete workup to establish a new baseline of what that patient's anatomy and functional status really is. Now for me, that always includes an upper GI and EGD, usually with pH testing, and I will also more selectively apply motility testing and other tests as appropriate based on symptoms. And I'll talk a little bit about what each one of these means to me, how I use them, and what information I'm looking to get out of them. I always like to start with an esophagram. This is my absolute favorite test for evaluating patients with achalasia because it gives me so much information and really provides a roadmap to where I'm going to be heading with any potential interventions. I can see structural abnormalities, if there's strictures or incomplete myotomies. I can see if there's a hernia or a fundoplication problem, any massive dilation, sigmoidization, or diverticuli, and I really start with this to hone in on exactly what I'm going to need to do to get this patient feeling better. Now, I also always recommend an EGD in any of these patients. And while it's nice to be able to get in there and drive around and see where the food and fluid is getting stuck, take a look at the anatomy, feel how tight things feel, I think the biggest benefit of an EGD is to be able to look at the mucosa in a way that the other studies really can't. That'll allow me to look for esophagitis, whether that looks like stasis or potentially GERD, and also just a PSA reminder that achalasia is a risk factor for squamous cell esophageal cancer, so any patient presenting with dysphagia and a history of achalasia needs to have a close mucosal evaluation to make sure that this isn't something that is missed. Now, when I'm doing my EGDs, I usually routinely include pH testing. And that's because we know that after a myotomy, rates of increased acid exposure are extremely high, ranging anywhere from 30 to 60%. Now, while Poem is traditionally a little more guilty of this, Heller is by no means innocent, and even with a fundoplication in place, you can have even silent episodes of acid reflux that may be causing inflammation, irritation, and leading to those strictures. The good news is GERD is probably the easiest one of these things to treat, so you want to find it if it's there. Because if you miss it and you're wrong and you choose to extend that myotomy based on symptoms of dysphagia alone, you're going to make this problem worse rather than better and be in a really difficult situation. Now, additional workup I use in a little bit more of a specialized way. While a lot of people will argue that a formal high-resolution manometry is necessary for the evaluation of patients with recurrent dysphagia and achalasia, I tend to be a little bit more selective about where I use formal HRM. And that's because I think it does have a couple issues in these settings. And as long as I am 100% sure that the first diagnosis was correct and it was in fact achalasia, this test doesn't give me a lot more. Patients don't really like it, it's hard to tolerate, it can be very difficult to place these catheters in sigmoid or tortuous esophaguses. You may not even get it past the lower esophageal sphincter. I already know they have aperistalsis, so I'm not looking for that data. What I'm interested in is that area of obstruction. And we know that IRP is not necessarily the best test to look at the true dynamics of a lower esophageal sphincter. We've seen in primary valve evaluations that even with a normal IRP, the distensibility of that EGJ junction can still be reduced. And that is associated with impaired emptying and recurrent symptoms. And what IRP means in the setting of a previous myotomy is even less evaluated. We don't really know how to interpret that and what it means. So this is an area where I really like to employ EndoFlip. And for anybody unfamiliar, it's a simple balloon catheter system where I can actually inflate this device within the esophagus at the level where I'm seeing an anatomic issue, and I can measure in the live time exactly what the distensibility and movement of that region is to help me target my intervention. Now, many studies have shown that both distensibility index and cross-sectional area as measured by EndoFlip are associated with clinical response rates and post-procedural reflux. And while the data in using it for diagnosing recurrent issues is less robust, I do think that it really provides me a nice way of getting in endoscopically, looking exactly at the area that I'm concerned about, and targeting my intervention. Now, just a small note, don't forget about gastric emptying. Many patients who have esophageal motility disorders will also have gastric motility disorders, either from primary motility problems or potentially a vagal injury during their index operation. And this is another one that you don't want to miss. It's pretty easy to diagnose, it's pretty easy to rule out, and if you do find it, patient may be having overflow reflux from delayed emptying, then you might be able to target the pylorus rather than going after the lower esophageal sphincter. So again, something you don't want to miss, keep it on your differential and consider this if a patient is having symptoms that point you in that direction. So now that you've done a very thorough workup and you know exactly what the problem is that you're going to be going after, you get to decide how you treat these patients. And I always start with non-surgical management. Now, the good news is some of these diagnoses are going to respond very well to medications. If you find that this is just GERD, the vast majority of patients with GERD after a myotomy are going to respond to PPIs, are going to have significant improvement in their quality of life, and they're not going to need additional revisional surgery. Spasm can also be treated with things like calcium channel blockers and nifedipine, but I would caution against a few medications, one being Botox, which we often use in primary cases, but in revisional cases, it is not recommended due to increasing levels of fibrosis and high failure rates. Also, narcotics will only worsen your motility issues and are not going to help with visceral pain, so those should be avoided. But even if it's not medication responsive, surgery is still not my next step. Pneumatic dilation actually, fortunately, has extremely good rates of success in the treatment of recurrent dysphagia in patients either with a previous Heller or POEM. Now, I am rather anti-pneumatic dilation in the primary setting, and I'm quite quick to go to a surgical myotomy as I think that it's more definitive. But in the redo setting, there's really good evidence that this is a safe approach to start with. It does take a couple treatments, mean of 2.5, and there is a higher risk of perforation in the first few months after your operation, so avoid it early, but it is not an unreasonable attempt to make with a patient. Now, this does raise the question of whether this is burning bridges. Are we going to make it harder if we eventually have to do a redo? Well, fortunately, the data on this, though a bit sparse, looks like it really doesn't. There's some good papers on redo Heller myotomy that show no difference in complication rates or technical difficulty, whether or not a previous pneumatic dilation was performed. The POEM data is a bit more controversial, but there's still nothing really definitive to say that pneumatic dilation should be contraindicated in these settings, so this is always my first go-to. Now, unfortunately, there are going to be patients who do not respond to medications or dilation, or who have a disease process that isn't going to respond to medication and dilation. And that's when you have to decide whether or not surgery is the right step to take. And of those patients, we see that about a third of them are progressing to surgery because of issues related to GERD. And if they failed their PPIs, it's very reasonable to go ahead and operate and give that patient a fundoplication. About half of them are coming back with obstructive issues, so whether that's a fundoplication problem or recurrent hernia versus an incomplete myotomy. Again, if they fail our other techniques, go ahead and operate. You can fix that fundoplication, you can fix that myotomy. A very small percentage will progress to end-stage motility, and you may need to consider more drastic interventions, which we'll hear a little bit more about later. Now, I'm always pretty happy when it ends up being GERD, because that's really the easiest one of these to fix. And even if they fail medications, going back in operatively and adding a fundoplication, which does end up being required in a small minority of patients, is a very safe thing to do. Of note, I would always recommend doing only a partial fundoplication in these settings. I would never recommend a full Nissen in the setting of achalasia, but either TUPE or DOR are associated with excellent clinical success rates. Now, there certainly are papers also looking at more novel techniques such as POEM fundoplication or TIF in these settings, and the small centers that have done them have shown very high technical success rates. But there are also concerns about whether doing a TIF in the setting of a previous myotomy and potentially firing those pins through a myotomized portion of esophagus or stomach might be a problem. So I would say unless you are very experienced in TIF, this is not yet standard of care, but is certainly something that has been shown to be effective in the right centers. Now, if you do find yourself in the position of having to do a redo myotomy, it's a tough position to be in. I remember this is the type of case I sort of lose sleep the night before. But fortunately, they are actually very, very successful. And both redo Heller and redo POEM are associated with high rates of clinical success, up towards of 85%. Now, neither of those numbers are actually quite as good as a primary myotomy, but I still find them to be pretty impressive overall. Unfortunately, they do come with a higher complication rate, both for redo POEM and redo Heller, where we see higher rates of all complications, longer operative times, and higher rates of conversion to open. So one of my favorite quotes is by Albert Einstein, and my residents hear me say this a lot, that insanity is doing the same thing over and over and expecting a different result. And while I've shown you that redo myotomy, either Heller or POEM, is safe, effective, and clinically successful, it might stand to reason that doing something different could potentially be easier and more effective. And just think about that. Think about being in a position of doing a POEM after a Heller. That would allow you to create a much longer, more extended myotomy in a much less invasive way than going back in and doing a revisional operation. It's relatively easy to find a new POEM plane, as the Heller plane is typically performed anteriorly, and the POEM plane is more likely to be lateral. Also, most patients already have a fundoplication, so you've already addressed the GERD risk. So there's a lot of potential benefits here. And the people that have done this have shown incredibly high rates of technical success and clinical response that are actually much higher than those of a redo Heller myotomy. Though granted, these are not head-to-head comparisons or randomized control trials. But what we find is that a POEM after Heller acts a whole lot like a primary POEM. The rates of complications are not significantly different than primary POEM, and compared to that redo Heller, you've got shorter OR times, less blood loss, less pain, and overall better recovery. And the same holds true for Heller after POEM. Again, it's good for targeted interventions on that lower esophageal sphincter and allows you to add a fundoplication if that's something that you need. Also, that anterior plane is usually undisrupted by the POEM, so you can just go in and do a regular Heller myotomy. So I just told you that every single option is technically feasible, every single option is safe and effective, so which one is it that you do? Well, in general, I'm always happier when I wake up in the morning and I have a primary surgery to do compared to a revisional surgery to do. So my protocol for this, and this covers a little bit of everything that we talked about today, but I will bring your attention down here, is that if they've had a POEM, I'm going to do a Heller. If they've had a Heller, I'm going to do a POEM. You can save a redo of your index operation for the next step, but ultimately you do need to know if everything has been lost or it has progressed beyond reason and the point of needing end-stage esophagus or possible esophagectomy, which is coming up next. So just a few tips to finish off here with how you do this well. I think it's really important to have a good mental model. Know what you're getting yourself into, get the old op notes, know where that old myotomy was, because the single best thing you can do to be successful is form your new myotomy in a new location. So if it's a previous Heller, you got to avoid that anterior plane, either by going to the right of it with a redo or doing a POEM. And the same holds true with a POEM. You got to know where that old tunnel was so you can avoid it. I always also try to make sure that my myotomy is adequately extended both proximately and distally, which can be a hard thing to do, which is why we get incomplete myotomies sometimes. So this is another area where I like to employ EndoFlip. And I use this intraoperatively just to make sure that I'm getting an adequate myotomy of the target area, because if you leave the distensibility too low, you might get dysphagia, and if it's too high, symptomatic reflux. And an ideal target will help you optimize these outcomes, though this is a little bit beyond the scope of this discussion. Now, I personally do use the robot for all of my revisional surgery as well as for all of my Hellers. There are some papers showing lower rates of mucosal perforation, both in primary and redo Heller myotomy with the robotic platform. There are also plenty of papers showing good success rates with the laparoscopic approach, so while it's not necessary, it is my preference to use the robot in these cases. So in conclusion, while revisional motility surgery can be difficult, can be technically challenging, can be a clinical dilemma, as long as you have a really appropriate workup, you know what you're going after, and you have a good treatment plan, you really can provide excellent outcomes to these patients by being willing to undertake these operations. The best results, though, are obtained in high-volume centers and people who have had a lot of primary experience. So if you're going to take this on, just make sure you've got the support, make sure you've got the plan, but don't be afraid to offer this to patients, as you can really, really help them. Thank you so much for your time and attention. Look forward to the discussion.